Hello there, and welcome to this symposium for this afternoon. First, a couple of housekeeping things to just touch on. We'd like to remind the delegates to use the chat function next to the live stream to make any comments, like to interact with each other. Really nice to see the conversations that are happening there, so please do use that. If you're using social media, don't forget to use the conference hashtag, which is hashtag IEPA 2021 virtual. It's really lovely to see things on there in terms of people's reflections on the conference and highlights. So do make sure to check that out. We'd love to have questions as well when we get to the panel. So do make sure that you use the Ask a Question button underneath the live stream, and we'll make sure that we pose those to the panel at the end of the presentations. But you can be posing the questions at any point through the presentation, and we'll come to that towards the end. But now, in advance of this really wonderful symposium that we have this afternoon with some fantastic speakers, I'd like to introduce our first presenter, Dr. Amy Hardy. Dr. Hardy is a clinical psychologist lecturer, IOPPN, King's College London, and a consultant clinical psychologist and trauma-informed care lead at the Psychological Intervention Clinic for Outpatients with Psychosis in South London, Maudsley NHS Foundation Trust. Please welcome Amy to this afternoon's symposium.
Hello everyone, so it's my pleasure to be here today, and I'd like to start with a big thank you to the IEPA for organising our wonderful conference programme and the symposium. So we're going to be focusing on an area which I'll assume is close to many of us, how we can understand the impact that trauma has on psychosis in order to support people with trauma-related psychosis to move on in their lives. And in this talk specifically, I'm going to be focusing on research relating to the psychological mechanisms that contribute to the pathway from trauma to psychosis. And I'll share some hypotheses from my own work regarding what that might mean in terms of what we want to be kind of focusing on in therapy, which I know that David and Laura and Filippo are going to be picking up more on in their talks and expanding on further. So before we start, I thought it might be helpful to share a framework for defining trauma. What is it that we mean when we talk about trauma? So this framework that I've gone with, as you see, refers to the 3 E's. And in defining these 3 E's, I think it's helpful in supporting us to think about our question of what are the pathways from trauma to psychosis. So the first E then refers to the event, so any event that's psychologically or physically threatening. The second E refers to the experience or the reactions at the time of the event across a range of domains. And the third E refers to the effects of the trauma. So, and again, may span cognitive, emotional, behavioural, physiological and/or interpersonal domains potentially. And as I said, in this definition, it's potentially giving us some clues about what is it about trauma that might lead to a pathway to psychosis. Is it something about the events themselves? And we certainly know that certain types of events are more likely to be negatively experienced and then lead to detrimental effects. Or maybe it's something about the events effects themselves. Maybe that might explain why some people develop trauma-related psychosis following a traumatic event, whereas someone else might not do. Maybe it's because the event in that given context has led to certain types of effects that then might fuel psychosis. So let's hold that definition in mind then as we delve a little bit deeper into what the relationship is between trauma and psychosis. And I imagine this may well be familiar to many, or if not all of you, but we know that rates of trauma, alongside being ubiquitous in the general population, are more common still in psychosis, specifically in relation to interpersonal victimization. So that's physical, sexual and emotional abuse, or physical or emotional neglect. although it's of note that the rates that are found in psychosis are kind of comparable to some other diagnostic groups, such as people with personality disorder diagnoses, PTSD, or depression. And I guess that's of interest, this increased rate of interpersonal victimization, because if we think about our question of the pathways from trauma to psychosis and the 3 E's that I shared earlier, we know that it's precisely this type of event that's likely to give rise, understandably, to a really difficult experience at the time and potentially negative effects afterwards. And of course, people with psychosis are also more likely to be experiencing traumatic events as a consequence of their mental health problems, either due to those difficulties themselves or factors associated with psychosis, such as involuntary admissions. And these psychosis-related traumas, of course, intersect with other structural adversities that people with psychosis are more likely to be affected by, such as poverty and discrimination. So given all this, then, unsurprisingly, the lifetime and current prevalence of PTSD is higher in people with psychosis compared to the general population. It's about 1 in 6 to 1 in 8 people currently with psychosis diagnoses would also meet criteria for PTSD. And of course, a much wider range of people will be experiencing kind of sub-threshold PTSD or other types of traumatic stress reactions. And it's specifically in relation to our question of the pathways from trauma to psychosis. The evidence seems consistent with this idea that trauma is, at least for a subgroup of people, playing a causal role in psychosis, because there is evidence of a replicable prospective and dose-response relationship between trauma and psychosis, with Filippo's meta-analysis indicating that people who have experienced childhood trauma are about 2.8 times more likely to experience psychosis. And another meta-analysis has also indicated that there appears to be links between specific types of trauma and specific types of psychosis difficulty. And this is based on the hypothesis, or this has led to the hypothesis that maybe certain types of traumatic events, such as sexual abuse, are particularly likely to trigger certain types of trauma effects, such as dissociation, which may be particularly potent in shaping, for example, voice hearing. So given then that the evidence does seem to be pointing towards this causal relationship between trauma and psychosis, the next important sort of part of that potential causal picture is determining if there are mechanisms underlying that relationship that could be feasibly accounting for it. Now, over the last 2 decades, there's been a wealth of research done in this area. And I just wanted to share with you or to highlight the 4 most recent systematic reviews that have been done in the area. I'm putting them up here now so that you can look them up and come back to them to read further if of interest to you. Now, of course, these reviews have used sort of slightly different inclusion and exclusion criteria in terms of their studies. They've each taken a slightly different approach to quality assessment. But nonetheless, despite these different emphases, they're fairly consistent in their conclusions, which I've summarised on this slide here. And they are certainly highlighting a role for psychological processes as mediating the trauma and psychosis relationship. There particularly seem to be a key role for emotions and emotion regulation, so supporting the idea of an affective pathway from trauma to psychosis. And consistent with that, there also appear to be a role for other trauma-related processes, so schema and beliefs, dissociation, which is arguably a form of emotion regulation, insecure attachment, which again arguably comprises of schema and beliefs and emotion regulation, and also other types of PTSD symptoms, such as re-experiencing. Now, an important caveat or limitation of these reviews is that the study quality is currently largely in the low to moderate range, so we certainly need more robust designs to improve our understanding. And another key issue is that the variables that have been implicated, or processes that have been implicated, are overlapping, and they're certainly likely to be interacting. One of the difficulties is that much of the work that's been done in the area tends to look at, one mediating process, maybe a handful at most, in relation to one psychosis outcome. And so in relation to our kind of question of, well, what processes should we be targeting in therapy, that then presents a kind of limitation for us. Now, network analysis or network theory provides a potential means for addressing this challenge, because it provides a way of analysing interactions between or within complex systems. So this network analysis that myself and David were involved in is the first network analysis to our knowledge that looks at post-traumatic stress and psychosis symptoms. And we did this based on the hypothesis that post-traumatic stress symptoms are also proxies or trauma-related mechanisms that might be playing a role in psychosis. And we looked at this in this sample, who all had clinically significant post-traumatic stress symptoms and either lifetime or current psychosis symptoms. And we specifically hypothesized in terms of our PTSD symptoms or trauma-related mechanisms, that avoidance and numbing and hyperarousal were reflective of emotion regulation, that re-experiencing represented episodic memory, and that post-traumatic cognitions was reflective of schematic beliefs. And so this is the network graph, which shows the interactions between the PTSD and psychosis symptoms. So re-experiencing is shown here in orange, avoidance and numbing in blue, hyperarousal in green, trauma-related beliefs, which are currently a type of PTSD symptom or mechanism, in pink, and psychosis is shown there in relation to voices and delusional beliefs in yellow. And the lines between the nodes or the circles or symptoms, they reflect the relationships between them, and the more opaque they are, and the thicker they are, the stronger the association. And the little pie charts around each of the circles or nodes illustrates the extent to which that node could be predicted by the other nodes in the network. And so what you can see here, what we found was that the nodes that were most influential, the mechanisms that were most influential in the network, were negative beliefs about the self and world. We also found that negative self and numbness were most predicted by their neighbours. We then did this bridge symptom and shortest path analysis. So this looks at all the trauma-related mechanisms that we included, so emotion regulation, memory, and beliefs together, and specifically tries to examine, well, which of those was bridging the relationships between post-traumatic and psychosis symptoms. And then the shortest path analysis, which is kind of akin to a sort of mediation analysis, looked at which symptoms or mechanisms accounted for the relationship between psychosis on the one hand and flashbacks on the other, or vice versa. And so the green nodes here represent the bridge symptoms, which, as you can see, were negative beliefs about the self, the world, and others, and self-blame and hypervigilance. So they bridge psychosis and PTSD. And the shortest path between flashbacks and voices and delusions was explained by negative beliefs about this world and a sense of fall short in the future, which arguably again is a type of belief. So what can we conclude from that network analysis then that looked at those mechanisms together? Well, seems to be hinting at potentially quite a key role for trauma-related beliefs. And what's interesting about that is it seems to be in line with the findings from phenomenological research that's looked at how the experience of trauma maps onto or relates to the experience of psychosis. And this has particularly been looked at in relation to voice hearing. And there's, it's often been done by having independent raters code the content of trauma and voice hearing, specifically often in relation to whether there appears to be evidence of direct or content links, so where the voice hearing content seems to map on directly to the experience of trauma, versus thematic or more kind of indirect associations where there seems to be more of a symbolic kind of link or thematic link between the trauma and the voices, and the content links are hypothesized to reflect trauma memory intrusions or episodic memory intrusions, with the thematic associations more hypothesized to reflect beliefs and emotional processes. And what this work tends to find is that indeed it is the indirect or thematic associations that appear to be more common. And in this other recent study that is currently under review, that actually worked with both independent raters and people with lived experience of voice hearing directly, we found a similar pattern in terms of the lived experience perspective, where relational links were kind of more commonly reported. And we also interestingly found, in line with the network analysis findings, that when a trauma was characterized by a sense of negative self, that was also significantly associated with the voices being characterized by a theme of negative self. So what can we conclude then overall based on this work? Well, it's obviously preliminary given the methodological limitations that I've kind of highlighted, but currently it seems that maybe trauma-related emotions and beliefs might be most influential in the pathway from trauma to psychosis. Threat processing in relation to kind of hypervigilance seem to be more central than dissociation, which is interesting in terms of kind of our some of our traditional conceptualizations of trauma and psychosis. And similarly, episodic memory seem to be having less of a direct influence, relative at least to emotions and beliefs. Now, a big caveat, though, or limitation of these conclusions is that the most influential or central variables or processes within the pathway might not necessarily be those that need to be targeted in order to kind of destabilize or change the network. Indeed, it might be that other mechanisms, such as episodic memories, need to be targeted in order to shift the trauma-related beliefs, for example. And so therefore, again, going back to what I mentioned earlier, we really need more robust designs, examining these relationships and pathways using momentary, longitudinal and interventionist methods to help us identify what these key destabilizing mechanisms are likely to be. That being said, what can we conclude in terms of targeting trauma effects in therapy based on what we know currently? Well, in my work, I've adopted a sort of pragmatic approach to conceptualizing the meta of a systematic review evidence. And I've grouped the main kind of psychological effects we need to be targeting in these three main areas, which include those that have been implicated in research, and also some that are implicated kind of in theory or anecdotally seem particularly key, but haven't been as systematically researched as yet. So the first area there, as you can see, we've already covered in terms of schematic beliefs about the self and world, but I've also included in their metacognitive beliefs about our thinking. Obviously, it's those beliefs that kind of reflect the meanings that we have about ourselves, the world, and our others, which are derived from our episodic memories, so our specific memories of our experiences in life, which is the third area of mechanism that might be driving trauma-related psychosis. And we know that these memories can affect us either by us kind of dwelling on them or experiencing intrusions in relation to them, either in the form of flashbacks, nightmares when we're sleeping, or perhaps even very decontextualized intrusions in the form of anomalous experiences or disruptions in self-identity. And then the third area is emotion regulation, which includes the emotions and all the intrapsychic, behavioral or interpersonal things we might engage in an attempt to try and keep ourselves safe or as safe as possible. And so we've iteratively over the years kind of distilled these mechanisms into a formulation framework, and the latest version of which is kind of shown here. And it highlights, as I said, how the interaction between managing emotions, trauma, memories, and beliefs shape the experiences that we have in the here and now, influence how we interpret them, and also then play a role in influencing how we feel and what we do in terms of our reactions, which then may paradoxically play a role in kind of maintaining them. So that gives us some clues then about kind of where we need to be targeting our interventions. And if we think about our therapies currently, in terms of the evidence-based recommendations for treating psychosis or supporting people with trauma, if we think about kind of reverse engineering those recommended therapies, what we see is that actually, in terms of CBT for psychosis, which is arguably trauma-informed anyway, it's already targeting those mechanisms that have been implicated. So emotions, emotion regulations, and beliefs, and how the interactions between them give rise to anomalous experiences. And similarly, trauma-focused therapy focuses on those processes with the addition of also targeting trauma memory. And so perhaps it's for bringing together of these approaches in a broad umbrella of trauma-focused CBT, and I'm including second and third wave and a broad range of memory intervention approaches, including EMDR within that, that we have our kind of a therapy approach that supports us in addressing the mechanisms that seem to be playing a role in trauma-related psychosis. But of course, the key outstanding issues are we don't yet know what we should be doing, or we know relatively little currently about what we should be targeting for whom. And so we need a lot more evidence around that. And I'm excited to see how the research will progress in the coming years. And we also need more evidence to inform our understanding of what trauma-focused therapies can be implemented in a safe and acceptable and an accessible way in routine care. And I know we're going to be hearing more about that in the coming talks. I'll just finish by sharing an example from my own work. So the STAR trial is led by Emmanuel Peters. It's for Study for Trauma and Recovery. And we're looking at trauma-focused CBT for psychosis compared to treatment as usual, following people up at over 2 years. And we are doing some mechanistic research as part of it, which will hopefully inform our understanding of trauma-related psychosis and mechanisms of change in trauma-focused therapy if the trial is effective. This is an overview of our therapy protocol, and I hope this kind of highlights how we, alongside doing our kind of conventional assessment and formulation and staying well planning, as we would do in any therapy, we support people to manage problematic emotion regulation by helping them to rebuild their life, learn about common effects of trauma, manage emotions, and promote a sense of control. And we work on those problematic trauma-related beliefs and memories, and the interactions between them that give rise to anomalous experiences. And throughout STAR, we're going to be doing really detailed monitoring of adherence and competency, which again, we hope will really support us in developing our understanding of how we can best tailor therapy to support people's recovery. So I'm just going to leave it there by thanking my wonderful collaborators in the trauma and psychosis field, whose it's an absolute privilege to work from. Thank you so much for listening, and I'll look forward to our Q&A. Thank you.
Thank you so much, Amy, for a fantastic presentation. That was wonderful. I'd like now to introduce our second speaker, Dr. David Vandenberg. Dr. Vandenberg is a clinical psychologist, head of psychosis research, Panacea, specialism lead for psychosis, and the lead for the top, GGZ early detection and intervention team in The Hague. Please welcome David.
So thank you, Kate, for this introduction, and thanks to the IEPA conference organizers for inviting us for this symposium. I'll be talking about trauma-focused therapies for post-traumatic stress in psychosis, and more specifically the reprocessed randomized controlled trial. I'm doing this work with a lovely research group with colleagues from the Netherlands, the United Kingdom, and United States. We have 2 great PhD students on the project, Simone Burger and Tineke van der Linden. We're grateful to the sponsor, Stichting Tot Steun, and especially to all the brave therapists and participants without whom none of this work would be possible, of course. As Amy addressed, trauma is unfortunately highly prevalent within people with psychosis. If we look at our own research and look at reviews on prevalence of trauma in psychosis, we can easily assume that about 1/3 of the people with psychosis have been sexually abused in their childhood, that about half of the people with psychosis have suffered physical abuse, and we see very high numbers of emotional abuse, emotional and physical neglect within this group. And what's especially typical for people with psychosis, that we see combinations of these types of childhood abuse that have influenced how people are able to develop as a human being. And Amy has already talked about how these traumatic experiences via biological and psychological mechanisms greatly increase the odds of developing symptoms of psychosis. And she also addressed the fact that as a result of these traumatic experiences, quite a lot of people with psychosis experience traumatic stress symptoms that meet full criteria for PTSD. So within people with psychosis, about 1 in 6 to 1 in 7 have symptoms that meet full PTSD criteria. And quite often these PTSD symptoms are associated with childhood trauma. We now know that, unfortunately, also the psychosis itself or the experiences within psychiatry can also be a traumatic experience within itself. We see very high rates of PTSD symptoms, so PTSD spectrum experiences, or full PTSD diagnosis directly after a first episode of psychosis. And these experiences can be related to either the psychosis itself or the experiences within psychiatry. And as an example, if you are 100% convinced that people are out to get you and that they're going to kill you, then in all kinds of situations, you'll be terrified. And these experiences within those situations can actually be traumatic for people and be relived in nightmares or flashbacks years after. Similarly, experiences on especially close wards with fellow patients, but also maybe not understanding the actions of mental health care professionals, for instance, feeling that you're being poisoned by people that say that they are doctors and nurses who are actually maybe part of the conspiracy that is out to get you. These can be terrifying experiences that people can relive for many years to come. And we know that the combinations of these different post-traumatic experiences, post-traumatic stress and psychosis experiences is a bad one. So we know that voice hearing and paranoia are highly prevalent within people with PTSD. And often that this indicates quite a lot of severity. Similarly, within people with psychosis, the presence of PTSD symptoms is associated with lower levels of functioning, more severe symptoms, lower well-being scores, and a greater use of antipsychotic medication, so using more medications but responding less well to it. And often we see that people are stuck in these vicious cycles, which I tend to call stable instability, in which the intrusive experiences that are part of PTSD, being tensed, being hyper aroused, not sleeping well, constantly fuel the psychosis and psychotic experiences, feelings of unsafeness, etc. And often people are stuck within these vicious cycles unless the traumatic stress symptoms are addressed. And fortunately, quite a lot is happening and has happened in both the clinical and the scientific world. When I gave a presentation quite a few years ago at the IEPA conference, I started my talk with a lot of slides about how both therapists in clinical practice and researchers tended to be reluctant to address trauma in people with psychosis, let alone treat them for these experiences. And I'm quite, well, it's quite an optimistic finding that a lot of work is currently being done in the field of psychosis and trauma. Some of the great work is presented here today by the other speakers. And if you look at targeting post-traumatic stress symptoms within people with psychosis, there are 3 treatments that have been tested in large, high-quality randomized controlled trials. The most tested intervention is cognitive restructuring, and the other 2 are prolonged exposure and eye movement desensitization and reprocessing. And the cognitive restructuring program was developed by the group of Kim Muser in the United States. It's a really nice program, also very complete. It's a 16-session program that includes several elements, among which psychoeducation, which is of course very important, breathing retraining, but the main focus is on cognitive restructuring of post-traumatic negative cognitions and developing action plans for dealing with feelings of unsafety and other trauma-related consequences. And this therapy has been tested within 2 trials within the United States with people with severe mental illness and found to be quite effective. Within these trials, a minority of the people had a primary diagnosis of psychosis, I believe 15% in one trial and about 30% in the other trial. But this protocol was also tested within a psychosis sample within the United Kingdom. The second treatment that has been tested in a randomized clinical trial in the Netherlands is prolonged exposure. Probably generally for PTSD, the most extensively researched intervention for post-traumatic stress disorder. Prolonged exposure, to put it short, is like any other exposure therapy. The basic concept, if I simplify it a bit, is that people with post-traumatic stress disorder have kind of a phobia for their own memories. So what we do is that within a safe therapy setting, we help people to expose themselves to those memories, to help them experience that they can actually deal with these memories, maybe change the narrative a bit, and relearn that they are actually safe, that they can deal with these experiences, and that they can think back of these experiences without being super stressed all the time. And this is in vitro exposure, but within this therapy, there are also in vivo elements in which people expose themselves to triggers such as the scent of alcohol or other some places, people, pictures, to help overcome their fear of their own memories. The last intervention is EMDR. It's a very popular intervention in some countries, less in others. It has, in my opinion, quite a bit of similarities with prolonged exposure. It's also a very trauma-focused intervention in which you go back to traumatic memories, and especially to these sensory elements of the memories. But the main difference with exposure is that you look back at the experiences more from a current perspective instead of really reliving it within a session, and that you are kind of distracted by the therapist, often by their fingers. Also here, there are quite a bit of elements within these therapies. I think all these three therapies have some cognitive elements, some behavioral elements. So there is quite a bit of overlap and similarity, though there are also differences. And one of the main findings for EMDR is that if you bring a memory back into your awareness and then are distracted by a stimulus like a finger, we often see that memories become less vivid and as a result less emotional to people. It is a bit early days, but when you look at the effects of these treatments on PTSD in psychosis, there are actually already reviews. There's a meta-analysis looking at the effects on psychosis, on PTSD, and there's a meta-analysis that Rachel Brandt and colleagues on kind of the side effects of doing this work. And if you summarize that, we find that these therapies are effective in treating post-traumatic stress disorder within people with psychosis. We find that they are safe. One study, the Dutch TTIP trial, actually finds that when you treat people for post-traumatic stress disorder, we see less crisis context, less self-harm, a reduction in days of being hospitalized, etc. So actually see a reduction of all kinds of adversities. We also see a neutral to positive side effects on, for instance, symptoms of psychosis. Mainly seeing that after addressing post-traumatic stress disorder, we see that people become less suspicious of others. It's still a bit unsure whether voices also become less stressful or less frequent after these therapies. And very interestingly, we're finding that these therapies are quite cost effective, which is, I think, quite important for researchers, but especially also for policymakers. This is maybe a bit of a complex graph, but what this actually shows, these two graphs, the left one, the blue one, is for EMDR and the right one is for prolonged exposure. The y-axis shows higher costs or lower costs, and the x-axis, so left, means less health, and right means more health or better effects. So the bottom right quadrant is what's called the golden quadrant, which means that you have health gain, although you're saving money. And as you can see within the EMDR group, virtually all people are in the cost saving but having more health benefits quadrant. And in exposure, it's also at least 2/3 of the patients. So that's really, really good. We're not only quite effective in addressing PTSD in people with psychosis, but in quite a lot of people, it actually saves money, especially because people tend to need less care after these interventions and have less days of hospitalization, etc. This needs to be replicated, but this is, of course, very promising work that really, really screams for implementation. So looking at these three therapies, it's good to understand that, as Amy addressed, they, although they partially overlap, they have different proposed working mechanisms. There are differences within the context in which these therapies were tested. For instance, in the United States is a totally different country with a totally different healthcare and social system than, for instance, the Netherlands, and that can, of course, influence outcomes. And also, these therapies were tested in different treatment dosages. So cognitive restructuring was, for instance, is a 16-session program, while EMDR and PE were tested with only 8 sessions, which also were found not to be enough for quite a lot of people. So in the reprocess trial, we are very interested in testing the effects of cognitive restructuring, prolonged exposure in EMDR within the same context and within a similar doses compared to a waiting list condition. So it's a 4-armed trial. I'll never do that again. And the primary outcome is the researcher-rated severity of PTSD symptoms. There's quite a lot of secondary outcomes in the domains of post-traumatic stress disorder, psychosis, but also factors like personal recovery and resilience. We'll be again looking at cost effectiveness and cost utility. I'm very interested in the work that we'll be doing on these working mechanisms, which I think will help answer questions of how these therapies work. Very interestingly, we will also do qualitative work to learn more about the experiences of people. It's a pragmatic single-blind trial. We're aiming to recruit 200 people before Christmas 2022. All these people will receive treatment as usual for psychosis. As I indicated, it's a 4-armed trial, and the 60 sessions will be delivered in 3 months with 2 sessions per week. So in the studies we did before, we had 1 session a week, and so we've increased the amount of sessions per week as we're seeing quite good effects also around the globe with more intensive treatment programs for post-traumatic stress. We have very few exclusion criteria. The inclusion criteria are people, are adults that are able to consent to participation, who have a diagnosis in the psychotic spectrum, and also meet full criteria for PTSD. The only exclusion criteria are practical. We want the medication to be stable so that the changes in medication don't affect the trial outcomes too much, and people have to be able to fill in questionnaires, etc. These assessments will be done at baseline, mid-treatment, post-treatment, 6-month follow-up, and at 12 and 24-month follow-up. And especially for the mechanisms, we'll be doing weekly evaluations of PTSD symptoms, psychosis symptoms, but also functioning adversities and revictimization. And those weekly evaluations will especially hopefully help us learn a bit more about how these different therapies work. Of course, this trial started running about 1.5 or 2 years ago. Doing large randomized control trials already difficult enough. Then we had a pandemic. So up to now, this hasn't been the most easy project I've ever done. Currently, we have recruited, I believe, 78 people in the trial. So we have about 120 to go. I'm optimistic that we'll make this. To summarize, there's beginning evidence for trauma-focused treatments addressing post-traumatic stress in psychosis. I think it's very important to implement trauma-sensitive care for individuals with psychosis, not only treating trauma-focused PTSD symptoms, but also just asking about trauma, about how that influences people. I think we really should do more in the realm of prevention, preventing trauma in children, preventing a negative impact on the development of children, shorten the duration of untreated post-traumatic stress, I would like to call it. In most of these trials, we treated people for traumas about 20 years after having started to have flashbacks, etc. We need to increase our understanding of trauma and psychosis mechanisms. Fortunately, we have people like Amy Hardy that are doing super great work in that area. And interestingly, and a nice bridge to the next speakers, We need to study how we can use these trauma-focused interventions for broader groups of people and also broader targets beyond merely post-traumatic stress symptoms. Thank you for listening, and I'm looking forward to our discussion later.
All right, thank you so much, David, for an excellent talk that really built on Dr. Hardy's presentation as well. So our third speaker today is Dr. Filippo Varese. Filippo is a clinical senior lecturer in psychology and an NIHR Advanced Fellow at the University of Manchester. Since 2018, Dr. Varese has been the director of the Complex Trauma and Resilience Research Unit, which is a collaboration between the University of Manchester and Greater Manchester Mental Health NHS Foundation Trust. This unit aims to improve understanding and clinical innovation of trauma, complex trauma, and related mental health needs in an applied setting. Please welcome Dr. Varese.
So greetings, everyone. My name is Filippo Varese from the University of Manchester. And in this presentation, I will provide you with an overview of recent research on the prevalence and clinical impacts of trauma, both in people with early psychosis and also in people who are at ultra-high risk for the development of psychosis. And through this research, hopefully I will provide a clear rationale for a couple of clinical investigations we are conducting in the UK to better evaluate the potential of trauma therapies in early intervention for psychosis settings. So, as I'm sure you are all aware, the literature on the relationship between trauma and psychosis is vast, and there is now convincing evidence that exposure to potentially traumatic life events can increase the risk of developing psychosis later in life. As part of meta-analysis we have conducted now over 10 years ago, we found that this relationship is not only robust and well replicated, but also follows a dose response pattern and is so robust that some of the analysis we conducted as part of this evidence synthesis in 2012 indicated that up to a third of cases of psychosis is potentially attributable to the impact of traumatic events in childhood. And more recent investigation and systematic reviews have further clarified the importance and the prevalence of trauma, specifically in the context of early psychosis. So, a recently published systematic reviews has demonstrated that childhood trauma is highly prevalent in clients with first episode psychosis, with levels consistently found to be superior to those observed in healthy controls, and also that childhood trauma in this clinical group is associated with more severe symptom profiles, both in terms of core symptoms of psychosis, such as hallucination and delusions, but also in other important clinical comorbidities, such as functional impairment, PTSD, the presence of dissociative symptoms, and also symptoms of depression and other important mental health complaints. But the relationship between trauma and psychosis is not limited to childhood trauma. People can be exposed to other potentially traumatic life events over the course of their lives. And importantly, people with early psychosis are often exposed to potentially traumatic events and circumstances that might stem from their mental health difficulties, but also aspect of the treatment they receive. So people with early psychosis typically describe experiences of distressing and sometimes terrifying symptoms that can be traumatic in themselves, distressing contact with mental health services, such as experiences of distressing hospitalization, coercive treatment, use of seclusion and restraints. And of course, they are also at greater risk of further victimization, exploitation, and of course, stigma and discrimination as a result of their mental health difficulties. So there is an accumulation in people with early psychosis of multiple potentially traumatogenic and perhaps re-traumatizing experiences that can have an impact on the person's mental health and well-being, and also limit and reduce their opportunities for longer-term recovery. And given this high prevalence of trauma in people with early psychosis, is perhaps not surprising that levels of post-traumatic stress are equally elevated, as demonstrated by a number of systematic review and meta-analysis of this literature. So, for example, a recent meta-analysis has indicated that following the first episode of psychosis, approximately 1 in 2 people report distressing post-traumatic symptoms. And also these symptoms can be so severe to be associated with a full-blown post-traumatic stress disorder presentation. So 1 in 3 people potentially meet criteria for full-blown post-traumatic stress. Another recent systematic review of the literature of PTSD in psychosis has suggested that between 14 and 47% of service users can experience what we call psychosis-related PTSD, meaning they present with PTSD symptoms that are the direct result of experiences of psychosis in themselves, such as terrifying symptoms, and also a range of potential iatrogenic traumas and circumstances that people have exposed to as part of an acute psychotic episode, for example. So whenever we are working with a person presenting with a first episode of psychosis, we are potentially presented with people reporting complex trauma histories that have potentially also multiple layers, including childhood trauma, experiences of adult victimizations, iatrogenic traumatic events, exposure to discrimination and stigma, and also the potential traumatic impact of psychosis in itself. And all these factors can have an impact on the person's well-being, but also influence the nature, the content, and the severity of the psychotic symptom that people struggle with in the first place. As a matter of fact, there is a ever-growing body of literature suggesting that the emotional and psychological consequences of trauma, such as, for example, the experiencing symptoms or negative beliefs about the self and others that people can develop as a result of adversity, may represent important underpinnings of psychotic experiences, including hallucinations, delusions, and paranoia. The findings of several systematic reviews and meta-analysis also suggest that these post-traumatic sequelae may be involved in the maintenance of psychotic symptoms in clinical samples, and also in the development and maintenance of subsyndromal psychotic experiences. So in the light of this literature, it's perhaps not surprising that there has been also a growing interest in studying the link between trauma and prodromal symptom of psychosis, and the importance of trauma in people at clinical high risk of developing psychosis. And there is now a range of systematic reviews and meta-analysis that have monitored and documented the prevalence and impact of trauma in this high-risk group, which I'm briefly summarizing in the next couple of slides. First of all, we know that experiences of trauma, and in particular childhood trauma, are not only prevalent in people who have already developed psychosis, but are already prevalent in people who are at risk of developing psychosis, with systematic reviews suggesting that between 54 and 90% of people at ultra high risk for developing psychosis have an history of childhood trauma, and an average prevalence rate estimated in one meta-analysis at over 85%. In addition to this, the literature suggests that trauma exposure in these high-risk groups is consistently elevated compared to healthy controls, in particular in relation to certain experiences such as physical abuse, bullying, and emotional abuse, but also for experiences such as experiences of neglect and experiences of sexual abuse in other studies. Another very important emerging picture from this literature pertains to the clinical correlates of having a trauma history in people with an at-risk mental state, in people at clinically elevated risk for the development of psychosis. Across a range of investigations, having a history of childhood trauma, for example, has been linked to a range of important clinical and functional outcomes, in particular more severe and more frequent attenuated psychotic symptoms, and also more severe functional impairments. And we know that these two variables are particularly interesting in the context of the psychosis prodrome, because they represent the two most robust predictors of a transition to a future first episode of psychosis across many clinical investigations. So trauma in itself perhaps is not a strong predictor of future psychosis. This is because trauma is so prevalent across people who already are at risk of developing psychosis, but the clinical consequences of having an history of trauma might put people at risk of transitioning to future psychosis, to a future psychotic disorder. So why is this literature of interest, and how can inform the way we support people who are either in the early psychosis group or are at high risk of future psychosis? Well, this evidence is timely in the light of other research evidence across considering individuals who have already developed psychosis, which suggests that interventions that are specifically targeting the psychological and emotional consequences of trauma might be beneficial to people with psychosis. So a range of clinical trials and systematic reviews have now confirmed that patients with psychosis are willing and able to engage in trauma-focused therapies. The trauma-focused therapies are safe in this clinical group, and that a range of trauma-focused interventions such as cognitive behavioral therapy, prolonged exposure, EMDR, can bring about significant amelioration in post-traumatic stress in people with psychosis, and the targeting post-traumatic stress in this clinical group can also lead to treatment gains in relation to the severity of psychotic symptoms. There are now several large-scale investigations worldwide, for example, both in the UK and in the Netherlands, as we've heard today, that are aiming specifically to evaluate the clinical and cost-effectiveness of trauma-focused therapies in people with psychosis and who also present with post-traumatic stress symptoms. But as yet, these clinical trials have not specifically considered people with early psychosis, a clinical group, as we said, that where trauma and recent traumatic events is particularly prevalent, in addition to history of childhood trauma, and also in the at-risk mental state groups. And these are the clinical uncertainties that we are specifically trying to target as part of several studies funded by the National Institute of Health Research in the UK. First of all, whether trauma-focused therapies can be effective in clients with early psychosis and clients at ultra high risk for the development of psychosis. We are trying to consider whether this intervention can improve symptoms of psychosis and not just comorbid PTSD, and whether they can also improve prodromal symptoms in people with at-risk mental state, and therefore potentially represent treatments that could augment already available preventive interventions for psychosis. So our first study that we are conducting to answer these clinical uncertainties is the EASE trial. So the EASE trial is a feasibility randomized controlled trial funded by the National Institute of Health Research, where participants with early psychosis supported by early intervention services in the northwest of England are randomly, or better have been, randomly allocated to either receive a 16 session of an EMDR for psychosis intervention that is being specifically developed by EMDR consultants in the UK to better target the clinical needs of this group, or receive the usual care that people receive from early intervention teams in the UK. Participants in this trial are followed up for 12 months following randomization to evaluate both the acceptability and safety of this treatment approach, but also the feasibility of conducting a future larger scale multi-site evaluation of this treatment. I'm not going to give you further methodological detail about this trial. This can be found in the protocol paper that we've recently published in Early Intervention for Psychiatry. This is the research and clinical team responsible for the EASE trial. It will be impossible to list them individually, but certainly every single person on this slide has made a crucial contribution to the development of this treatment and the development of the research evaluation that we are finalizing in this feasibility study. This study has been ongoing since January 2019 and took a little bit of a break because of the COVID-19 pandemic. We have now completed the randomization and the delivery of treatment as part of this feasibility trial, which is due to be completed in May 2022. So it is still premature to tell you much about the feasibility outcome and treatment effects that we are observing as part of EASE. However, in the next few slides, I wanted to give you a little bit of an overview of the clinical characteristic of the people who took part in this trial, particularly in relation to their trauma histories and trauma-related symptoms. So all participants that we recruited as part of EASE reported multiple and repeated exposure to traumatic life events, and we observed high levels of interpersonal victimizations and trauma. Again, not surprising considering the literature on people with early psychosis. And we also, of course, observed high levels of psychosis-related traumatic events. So, for example, almost half of the sample reported distressing contact with mental health services in the recent past. All participants in the trial also reported at least one traumatic event that they regarded as significantly impacting their current well-being and mental health in the here and now, with high self-reported ratings of perceived impact of these traumatic events. And when it comes to trauma specific or trauma-related mental health difficulties, almost 70% of our participants actually met criteria for post-traumatic stress disorder, with actually almost 60% of the sample meeting criteria for complex post-traumatic stress disorder on a screening measures. We also observed high levels of dissociation, with levels actually higher than those typically observed in previous investigations on psychosis samples. So this is that was a trial that we are doing specifically to evaluate the role of trauma therapies in the context of early intervention or early psychosis service user. But in parallel, we have started a program of research that is specifically trying to evaluate the value of trauma therapies in people at ultra-high risk for the development of psychosis. This is a project called Restart, also funded by the National Institute of Health Research, which ultimately aims to design and deliver a multi-arm feasibility trial comparing multiple trauma therapies in people at risk for the development of psychosis, both in terms of acceptability of treatment and also the feasibility of conducting a future larger scale evaluation of trauma therapies in this group. The research at the moment comprises two components before we move on to a clinical trial. The first one is a relatively small cohort study that we are using to map common psychological consequences of trauma in this group and identify tractable trauma-related mechanisms that are associated with greater severity of attenuated psychotic symptom and functional difficulties in people at high risk for the development of psychosis. In parallel to this, we are also conducting qualitative interviews and also stakeholder consultation with both service user and early intervention professionals to select and also adapt when needed trauma intervention that are likely to be most acceptable to individuals at high risk for the development of psychosis. So in this slide, I'm only presenting again the rationale or the rationale of these studies in a graphical format. Our first objective is to try to identify potential trauma-related variables and mechanisms that are linked most robustly to prodromal symptom of psychosis. This hopefully will inform the selection of a number of candidate therapies that could target these mechanisms, and this selection is going to be filtered by the knowledge that we are gathering through qualitative investigation and stakeholder consultation in terms of which of this treatment could be most acceptable to people at high risk for the development of psychosis, eventually leading to a multi-arm feasibility randomized controlled trial. Thank you very much for listening, and I'm looking forward to further discussion at the end of the next presentation. Thank you very much.
Great, thank you so much, Filippo. It's a lovely presentation. For our final talk, and I should say thank you for all the questions that have been coming in as well. Please keep posting those. I think we're going to have a very interesting discussion at the end of this symposium. So for our final presenter, we have Dr. Tully, who's an associate professor in psychiatry and licensed clinical psychologist and director of clinical training at UC Davis Early Psychosis Program. They provide instruction in evidence-based treatment and assessment approaches for youth experiencing comorbid psychosis and trauma, with an emphasis on trauma-integrated CBT for psychosis in the context of coordinated specialty care. Please welcome Dr. Tully.
Hello, today I will be talking about treating comorbid psychosis and trauma in the context of coordinated specialty care, and specifically the protocol that my colleagues and I have been developing at UC Davis called Trauma-Integrated Cognitive Behavioral Therapy for Psychosis. So to start off, just provide a couple of definitions. A traumatic event is defined as exposure to actual or threatened death, serious injury, or sexual violence. Particularly relevant for transitional aged youth with early psychosis is understanding complex developmental trauma, which involves traumatic stresses that are repetitive or prolonged, involve direct harm or neglect by responsible adults, occur at developmentally vulnerable times in the victim's life, and have great potential to severely compromise a child's development. Trauma symptoms in psychosis is actually very common, compared to about 6.8% of individuals in the general population with a PTSD diagnosis. 23% of individuals with first episode psychosis have a PTSD diagnosis. So that's 1 in 5 individuals. Up to 80% of youth at clinical high risk for psychosis also endorse a lifetime history of traumatic events and victimization during childhood, even in the absence of a PTSD diagnosis. Trauma, however, is poorly diagnosed in individuals with serious mental illness. For example, clinicians often struggle to make the differentiation between what might be a hallucination or suspiciousness versus a trauma symptom. So that distinction between a trauma symptom like a flashback or re-experiencing versus a hallucinatory experience. However, it's something that we need to pay attention to as a field, because what we know from the research is that history of trauma exposure in psychosis leads to more severe symptoms, worse social functioning, and increased risk for bad outcomes such as substance use, hospitalization, homelessness, and risk for suicide. So it's something that we need to pay attention to. And also, while trauma is not causal in all cases of psychosis, the high rates of trauma and this link between trauma and psychosis suggests that they may play a significant role in the development of psychosis for a number of individuals. We propose that individuals with genetic and biological vulnerability for psychosis experience an initial traumatic event, which then alters their normal or disrupts normal developmental trajectory, leading to an increased likelihood of experiencing psychotic-like experiences. This in turn then affects the individual's ability to adaptively respond to stressful situations in the future, making them more vulnerable to future trauma and further victimization, which then escalates the cycle and leads to worse psychotic symptoms. So given this, high rates of comorbid trauma and psychosis in EP populations, and the putative causal links between trauma and psychosis symptoms, what should we do? Well, first, we recommend screening for trauma as standard as part of your intake events, both screening for exposure to events and symptoms associated with them. And here I've listed several validated trauma screeners that you could use. At our program, we use the PCL5 and the CATS for adults and children, respectively. If that trauma screener at your intake indicates that trauma symptoms are present, the next step is that we should use evidence-based practices to treat those symptoms. Empirically supported treatments for PTSD and other trauma-related disorders typically use exposure for traumatic events to reduce cognitive and behavioral avoidance that might maintain the symptoms. And empirically supported treatments include cognitive behavioral therapy, prolonged exposure, eye movement desensitization and reprocessing therapy, and cognitive processing therapy. And the common feature across all of these particular manualized treatments is the element of exposure. What we know from studies in established or chronic psychosis is that using these evidence-based practices with exposure does reduce symptoms. Despite this evidence, though, there are no standardized protocols for treating comorbid psychosis and trauma in early psychosis care. And trauma, in fact, is rarely addressed in the US in early psychosis outpatient settings. To understand the barriers to treatment and implementing trauma treatment in EP care, our colleague Casey Cragen surveyed 118 clinical experts across 121 early psychosis programs across 28 states in the US, and discovered that the top 3 barriers were clinicians having a very hard time differentiating between trauma and psychotic experiences. The fact that trauma and psychosis symptoms interact and can exacerbate each other made the differentiation even harder. And more importantly, that providers reported feeling as though they had inadequate training and supervision in the evidence-based practices for trauma and limited access to funding that could help them learn those skills. And this ultimately motivated our group at UC Davis to try to develop a treatment protocol that would be accessible for providers to implement in the context of coordinated specialty care, and something that we could train the next generation of providers on. And so was the birth of what we call trauma integrated cognitive behavioral therapy for psychosis, or TICBT-P. This is a treatment protocol that we developed in collaboration with the UC Davis Care Center, and it provides a framework for treating comorbid psychosis and trauma symptoms in early psychosis coordinated specialty care settings. Step 1 in TICBT-P is to conduct your assessment. You want to get a good assessment of psychosis symptoms and enough information to make a differential diagnosis of the primary psychotic disorder. we use the SIPs and the SCID to do that. We also want to do a trauma screener. And as I said before, we use the PCL5 and the CATS for that. And we also think it's very important to get a good understanding of any risk factors such as suicidal ideation, behavior, and non-suicidal self-injury. And we use the Columbia Suicide Severity Rating Scale for that. We put all of this information together to help guide our initial treatment approach. And we created a little decision tree for step 2, which is to figure out what is the priority in your treatment approach. Are you going to prioritize trauma over psychosis, psychosis over trauma, or do both at the same time? This is a decision tree that we use with our trainees, we use in consultation and supervision, and we try to make a decision at this point, following the initial assessment, as to which set of symptoms we think is most prominent and requires addressing in the treatment approach. Once we've made that initial decision, we move into step 3, which is to actually apply the TI-CBTP model, which we have developed as a staged model that can be embedded within the coordinated specialty care setting. Over here on the right, I have a diagram that best represents this stage model. Stage 1 is engagement in the coordinated specialty care model. So before you even launch into trauma or psychosis specific treatments, we want to make sure that the client and family are engaged in all of the elements of the model. And essentially what this involves is the primary clinician working with the clinical team to iteratively apply all elements that are noted here in the surrounding circle, including engaging the family and the support network in treatment, doing any case management or safety planning, engaging the client in supported education and employment services so they can meet their recovery goals, engaging the client and family in any group treatments that are relevant for them, working with our prescribers and MDs to do medication and health management, and doing sort of symptom tracking, ongoing assessment and case conceptualization and relapse prevention with the client. We estimate that this process in stage 1 takes about 6 months, with a pretty healthy standard deviation of 3 months either side, depending on the client and family's needs. Once the client and family are relatively engaged in the model and symptoms are relatively stable, we move into stage 2. And this is where we apply targeted empirically supported treatments to address the primary symptoms that are causing distress and impairment for the client. So if psychosis is primary and trauma isn't really present, you're going to take a more cognitive behavioral therapy for psychosis approach. If trauma is present and primary, you'll engage in using empirically supported trauma treatments such as TFCBT or CPT. And even if there are other needs that the client and family have, such as a need for family focused therapy, stage 2 would be where you would apply that. We estimate that this process takes about 12 to 18 months. Again, pretty healthy standard deviation of 3 to 6 months either side of this. That depends on the client and family's needs, relative stability, any crises that might disrupt the timeline. Once stage 2 is completed, you then move into graduation and discharge and referring the client and family out to the community, having graduated the coordinated specialty care program. So what I want to do now is I want to focus in on stage 2 and talk about what the components are, the core components for stage 2. So here they are listed. Core components are psychoeducation, skill building, enhancing supports, safety planning, and then after 1 month of exposure, 1 month of stability, we recommend moving into exposure as needed to address trauma symptoms. It's important to recognize, though, that exposure starts at psychoeducation. So the moment you start providing education about trauma symptoms, common trauma types, common reactions to trauma, is the moment that you begin doing that gradual exposure process with the client and family. And you do it gradually and in a hierarchical way in order to maintain stability. Depending on the nature of the trauma and the client's goals, you might engage in imaginal or in vivo exposure exercises. And we also recommend completing a trauma narrative where the individual gets to narrate what happened and then reframe it and make meaning out of the events. So I like to do a case example here. Jose was a 17-year-old Hispanic male that presented with his parents to our clinic after hospitalization for a first manic episode with psychotic features. He started medication and stabilized pretty quickly in our clinic. And we found out that he had witnessed a shooting in his neighborhood about 3 weeks prior to his episode of psychosis. And as a consequence of this, was refusing to return to school or go outside his home and was experiencing pretty significant trauma symptoms. So we, after engaging him and his family in the coordinated specialty care model and stabilizing his psychotic symptoms, we engaged in stage 2 of TI-CBT and applied these core components shown here. So we did psychoeducation with him, where we identified his symptoms of mania, psychosis, and trauma. We identified his reactions to trauma triggers, and we talked about the role of avoidance in maintaining trauma symptoms. We then moved on to skill building. For Jose, he found relaxation skills particularly helpful. He also was engaging in a fair amount of avoidance. And so we used SUDS ratings in session to capture his distress and show that habituation over time, even during psychoeducation. And we taught him cognitive coping skills to try and address some of his distorted cognitions around the trauma and his reactions, things like shame and guilt, etc. We worked with his parents to enhance his support. They were Spanish speaking, so our bilingual Spanish clinician worked with this family. We engaged them in psychoed sessions. We had Jose teach back the coping skills that he was using, and we reviewed the role of avoidance with the family so that they were able to support him in his own exposure exercises that he was doing at home. We did a lot of relapse management and wellness planning for Jose, and we discussed community safety. How would he know how to be safe in his neighborhood? How could he tell the difference between something that might be a trauma symptom or some suspiciousness and something that might be an accurate evaluation of the safety of his environment? After about 1 month of stability of symptoms and really good skills practice, we moved into exposure with Jose. This included, obviously, the SUDS ratings that he'd been doing throughout psychoed, so he'd even been doing exposure throughout. We did some imaginal exposures with him around returning to school, and then we moved on to doing some in vivo exposures, doing some campus visits with our case managers, and writing up a little narrative of how his perspective on the traumatic event had changed over time. Jose responded really well to this treatment, ended up going back to school and graduating and experiencing a significant reduction in both his trauma and psychosis symptoms, and has since graduated our program and appears to be doing really well. Of course, there are challenges to implementing trauma-integrated CBT for psychosis, and we have a few tips and tricks for doing that. Really common challenges if you're working with a client who has pretty significant cognitive symptoms as part of their presentation or cognitive impairment. We recommend keeping your material simple, keeping it concrete, and really focusing in on behavioral practice, doing a lot of behavioral experiments, doing a lot of exposure, and using visual aids. If you're working with someone who has prominent negative symptoms, we recommend first doing a fair amount of behavioral activation, integrating pleasure and mastery ratings, maybe even doing some emotion induction work to try and jumpstart the reward system. If you're working with a client and family that keep coming in with recurrent crises, we recommend kind of pausing, enhancing supports, bringing in community services. And then if these crises end up being therapy interfering behaviors, bringing in some other interventions like DBT or parent training to try and remove those barriers. Often with our clients, our families come in with a history of trauma exposure as well, and family members may have their own trauma symptoms that need to be managed. In this context, we tend to provide psychoeducation to the family members, and if necessary, support them and link them to their own care so that they can be the very best collateral support for their loved one while their loved one is doing their trauma treatment with us. Sometimes our clients will come in and they will sort of give a very rapid disclosure of trauma, perhaps sort of flooding themselves and us with all the details. It's really good to spot this and to kind of pause and slow everything down and stop the disclosure and explain the process of gradual exposure again and say, we're going to talk about these details over time. We don't need to talk about them all at once. And I want to make sure that you have a good set of coping skills to draw from when you do experience distress as you talk about this trauma. Specific to working with this in a psychosis population is often this question of the reality of the incident. So the first thing is we engage our collateral informants, we review records just to try and make a determination. Is this an event that really happened, or is it part of this person's psychotic symptoms? Regardless of whether it did or not, we're still going to pay attention to the trauma symptoms that are associated with the incident. If, based on the evidence that we have, it turns out that the event was unlikely to have happened, we still process the distress around that delusion or that hallucination using that trauma integrated framework. We might even write a narrative, we might even do exposures, we might even have psychoed around those kinds of common reactions. You wouldn't necessarily process the distress around the event itself, it's around the experience of that symptom. Another common challenge could be clinician fear of using exposure. We all got into this job not to upset our clients. We want to make our clients feel better. Exposure can have these sort of temporary exacerbations for folks. And it's at this point that I like to work with my trainees and say, hey, psychoeducation is part of gradual exposure. You're going to move forward slowly. You're going to shore up skills before you do anything more intense. And you're not going to break your client as long as you take this kind of gradual approach. And finally, and perhaps particularly importantly, is to recognize that as clinicians doing this work, we're vulnerable to experiencing secondary traumatic stress. And this is a really important thing to monitor. You want to make sure you're monitoring your own secondary traumatic stress symptoms. You want to engage in appropriate self-care. You want to make sure that your professional environment is trauma-informed. We want you to talk about this in supervision. And at our program, we have specific spaces where this happens. We have individual supervision spaces, group supervision spaces, and a secondary traumatic stress didactic where it is talked about very explicitly. So now that I've introduced you to TI-CBTP, I'm going to show you just a little bit of data on it. We evaluated 6 and 12-month outcomes for 22 early psychosis youth with significant trauma symptoms who were engaged in treatment at our coordinated specialty care program at UC Davis. 10 of these 22 individuals progressed to stage 2 of TI-CBTP and completed at least some trauma-focused components. 12 remained in the stage 1 at the time of us looking at this data. So they hadn't completed any trauma-focused components at that time. 2 major take-homes from the data. First, individuals who progressed onto stage 2, that is, received some trauma-focused work, had less severe overall symptoms as rated on the CGI and positive symptoms as rated on the CGI at baseline compared to individuals who remained in stage 1. So that's our black line here is stage 2 and our gray line is the stage 1. So you can see significantly lower symptoms at baseline in both of these categories and similar pattern in the other symptoms, but of course no significant differences. The second take home is that, as you can see from these plots, all individuals showed improved symptoms over the 12 months, which really is just in support of the coordinated specialty care model doing its job. Finally, some very preliminary data indicates that PTSD symptom severity does tend to decline in the individuals who received some stage 2 TI-CBTP. This is the symptoms at baseline between stage 1 and stage 2. And then these are individual trajectories for folks that we have the data on. I do want to really acknowledge this is a very small sample of data. I'm just providing it for descriptive purposes. But it's promising and we're continuing to collect the data. So quick summary of the preliminary results. I think one really important take home is that it's clear that TI-CBTP had no detrimental effects on psychosis symptoms, and it might reduce trauma symptoms. And so the take-home message that we're taking from this is that comorbid psychosis and trauma symptoms can be appropriately and safely treated using TI-CBTP within the coordinated specialty care model. The second thing is that individuals who proceeded to stage 2 within 12 months had less severe overall and positive symptoms at baseline, which indicates that individuals with more severe symptoms just might need more time in stage 1 to stabilize before they can go on to stage 2. And anecdotally, that's what we're seeing as we bring more folks into this protocol, and we'll be collecting data systematically on that. So that's a quick whirlwind tour of our TI-CBT protocol. I just want to finish up by acknowledging all of the people that make this work possible. Certainly, I am not the individual responsible for it. It's a big team effort with lots of collaborators, and here they all are, and there's more people helping. And I just wanted to say thank you to everybody.
All right, thank you to everybody. That was fantastic. Thank you, Tali, for the final talk there. We have a lot of questions, so thanks also to everybody's contribution. I'm just trying to get my screen up here. First of all, question to the group, kind of big one, but here we've got an assembled group of experts, so why not? Some theoretical orientations have the idea that trauma is causing the psychosis and that these participants should not be in FEP services. What do you all think?
I'll have a go at answering first. I suppose the evidence now is sort of unequivocal that trauma is associated with an increased risk for psychosis, and is sort of asking whether something is trauma or psychosis is essentially the wrong question to answer. Or to ask even. It's more actually, how can we help, addressing the mental health need that are brought about by these traumatic life experiences that we should be focusing on. So perhaps actually moving away from just, putting people into boxes on, predetermined sort of diagnostic classification and potential etiological model that we have for this classification, and try to understand the root causes of problems that might have brought about distress in these individuals, basically.
Thank you, Filippo. And I think extending from that, as we're sort of trying to think about this differentiation on some levels, or the helpfulness or lack thereof, are PTSD and CPTSD assumed to be the same or different in these presentations? Again, that's potentially a big discussion. So who would like to take that on?
I can share some thoughts about that. So, CPTSD, I guess, has been a sort of concept that's been around since Judith Herman sort of proposed this idea that perhaps people who have experienced kind of interpersonal victimization might have a different type of, or a more severe type of trauma response than was kind of traditionally conceptualized within PTSD in terms of, so traditional conceptualizations really focused on the re-experiencing the avoidance and the hyperarousal. CPTSD brought in this idea that perhaps trauma is also impacting on negative beliefs about self, emotion regulation, particularly in terms of dissociation, and also relationships with others. And under ICD and as measured by the ITQ, that kind of reflects that conceptualization of both PTSD and CPTSD. And I think, as was sort of reflected in our talks, we're all kind of focusing on those broader mechanisms as being key. So beliefs, emotion regulation and relationships, and we know that those play a role in psychosis. I think the one caveat I would say is I think it's, in some ways, it's a bit of an artifact of how we measure it. So Filippo's study did use the ITQ, and as we heard, 60% of his sample met criteria for CPTSD. Laura, I think in your service, you're using the PCL, which is more aligned to DSM criteria. And so it's not explicit that those people are meeting CPTSD criteria, but actually on the PCL, we are assessing beliefs about self, we are assessing relationships, and we are touching on aspects of emotion regulation and kind of numbness. So I think they are kind of captured under both diagnostic systems. And I think we're sort of, my guess is, but I'm interested to hear from the others, that we kind of, we view it as a kind of, umbrella sort of constellation of post-traumatic stress reactions.
I think from a treatment perspective too, when you're building a trauma narrative for someone who is perhaps presenting with more complex PTSD and these sort of chronic, like repeated stresses, that narrative isn't going to be focused in on one specific event. It's going to be focused in on these kind of hotspots, or thinking about, what are the kind of big themes of your traumatic response and your trauma story, sort of looking at the forest versus occasionally focusing on specific trees in that narrative. So from a clinical perspective, it just shifts how are you making meaning out of those traumatic experiences, and how are you putting that into the narrative?
Thank you. Anyone want to add to the question? David, were you going to come on? No. Okay, awesome. Thank you. A couple of questions came up, and I think there were some answers on the live stream there as well, but around assessment tools, particularly for you, Filippo, anything suggested for CPTSD and FEP and UHR groups, screening tools generally for traumatic experiences, and instruments to assess trauma that could be readily used in clinical care? So I catch-all a few questions.
Yeah, I think David answered already some of this question on the portal. So actually, me, David, Amy, we're all using similar measures, I suppose, also because we collaborate with each other. So in terms of screening for trauma, both in the early psychosis and UHR group, we are using the TAIL, which is a measure actually developed by Amy to screen for traumatic life experiences that are common in people with lived experience of psychosis. In terms of screening for post-traumatic stress, as Amy also already mentioned, we often use the PCL5 for capturing PTSD symptoms, and this is aligned with the diagnostic criteria for DSM-5 PTSD. In my research, we are also in the STAR trial with Amy, we are also using the ITQ, the International Trauma Questionnaire. So this is the first measure that is trying to capture separately, I suppose, as part of different scoring system, both the symptom of post-traumatic stress and the additional features that are believed to characterize complex post-traumatic stress disorder as operationalized by the ICD-11, which are called the DSOs. So these are all brief measures that can be used easily, I think, in routine clinical practice as well. We also encourage local clinicians in our areas to use them to, as part of their practice, and potentially to refer to our trials or to implement trauma intervention themselves.
I'd like to add one thing, because I think the ITQ and the PCL are good questionnaires to use when you want to assess someone multiple times, for instance, while doing therapy. The TSQ, the Trauma Screening Questionnaire, developed by Chris Bruin, who is super intelligent, but gave this PTSD screener a bit of a silly name, because it's a PTSD screener, but it's called the Trauma Screening Questionnaire. But that's an excellent screener because it's only 10 items. It's the DSM-4 reliving and hyperarousal items, and it has been validated as a screener for psychosis. So if someone scores above 6, there's a high odds of an actual post-traumatic stress disorder. So that's in routine clinical practice. If you want to implement routine screening, which I personally advise, because we know that if you don't ask about trauma on a routine base, people are less likely to disclose it. The TSQ is really efficient and has really amazing psychometric properties with people with psychosis. Yeah.
Just perhaps an addition to that, if I'm allowed, Kate, that perhaps definitely the TSQ is a good screener measures. I perhaps still see the value of having a little bit more of a fully developed measure or more extensive measure for capturing exposure, which the TSQ does not do so well. So still perhaps, the tail for, history of traumatic life events, and then for symptom and meeting criteria for PTSD, the trauma screening measure. Yeah, questionnaire.
Thank you very much. A question here about adapting the therapies. So to what extent do trauma-focused therapies offered to people dealing with a psychotic disorder differ from those used in other populations? Or put other ways, to what extent do you need to adapt these therapies for the specificities of this population?
I can speak a little bit to how we've been trying to do that in our program, and I'm curious on others' thoughts as well. I think, the biggest thing is that we have learned in our coordinated specialty care program, it's traditional to provide services for 2 years, and then folks graduate out into the community, and off they go. For our folks that are joining us with comorbid trauma and psychosis symptoms that are both contributing to the distress and recovery, we've noticed that we have to go slower. So the biggest adaptation is that they're typically staying in treatment with us for 3 years. And we have a handful of folks that have stayed on for longer than that, because the process of getting them fully engaged in the model and then stabilized and then ready to engage in trauma-focused work, specifically doing those exposures and writing that narrative, just takes longer. In our clinic, we're working with the most vulnerable members of our community. It's the Medi-Cal population. So it's the federal government's insurance program for supporting folks that live under the poverty line. So the clients and families that are coming to us, they're not just coming with 1 or 2 mental health challenges. They're also coming with a lot of systemic barriers, case management needs, kind of basic unmet needs that we're working with as well. So the biggest adaptation that we're making is kind of handling all of that first, so that that person is set up for success to do the intense work of trauma treatment. You're not going to be able to do an exposure narrative when someone is worried how they're going to be able to pay their bills, or if they've got housing, or if they're able to go to school. So you have to handle that first, and sometimes you have to circle back and handle those things and kind of pause the trauma treatment, make everything stable again, address some of the case management needs, and then go back into the trauma treatment. And so I think for the clinicians doing it, the best thing I can tell you is recognize it's going to go slower, be okay with that, and remember that you can kind of cycle back to the treatment, if you have to step away and address interfering factors.
Could I add to that? Oh, well, just a short comment, and then I'll leave it to you, Amy. I think I agree with virtually everything that Laura indicates, but I think none of these things are specific for psychosis. So I think trauma work in general with vulnerable people can be quite strenuous and difficult, and it's not a walk in the park. But I think that's also part of being a trauma therapist, that's what you're good at. But I think what I really would like everyone to take home is that people with psychosis are not all vulnerable, and they're not different species than people without psychosis. So especially if you're not working primarily with psychosis and someone has some psychosis symptoms, please don't use that as an exclusion criteria, because the psychosis itself is not a reason to withhold people from these interventions. Amy.
Yeah, I was really just going to sort of emphasize that point, David. I think you're right. The complexity is really about, as you highlighted so well, Laura, the social context and the contextual factors that contribute to challenges. The actual trauma therapy itself doesn't need to be significantly adapted for psychosis necessarily. We might want to attend to difficulties such as feeling more unsafe in terms of paranoia, voices and so on as we're doing sometimes memory work. But again, if you're doing complex PTSD work, these types of difficulties might come up as part of the therapy. And I guess one key issue in this area is this debate around stabilization and how much do you need to do first in order before you get on to doing the memory work. And just to share the sort of approach that we take in the STAR trial, and I use in my clinical practice, is that we do as much as is needed, but as little as possible. So we don't delay the memory work for doing sort of stabilization things for the sake of it. We get going, but obviously if we need to attend to stabilization issues, then we will do as much as we need to.
And maybe a final addition, I think with this group, especially people with severe psychosis, I often tend to say, do the stabilization, most of the work that we call stabilizing work, do it after the memory work. Because it is a group that if you help them stop having nightmares and flashbacks, they still have devastating negative ideas about themselves and the world and others. They still don't sleep well, etc. So, and there's also some questions about, we don't have EMDR, what should we do? I think another important take-home message, and I think Laura was a super final speaker indicating this, we need to integrate trauma-focused work within a broader, in my clinical work, CBT, or psychological formulation-based work and look at those mechanisms that I think we've all been talking about, and I think that's what we all, the speakers today, all share, is look at the individual and accept complexity a bit, and understand that trauma-focused interventions are one of the tools or elements within a much broader intervention program.
Brilliant, thank you. There's just a couple of minutes left. There's a couple of questions here about the role of antipsychotic medication. Do you think it has the role to interfere with the benefits of exposure? And if we see that psychopharmaceutical interventions are not supporting or not helpful when there's trauma presentations and CPTSD not being typically responsive to psychopharmacotherapy, what suggestions do you have in talking to medical providers involved in care to ensure evaluations take place? Very brief answers.
I have a brief answer, I think, about antipsychotics. I think it's good to understand that most of the patients that we've studied in large trials are people that are taking antipsychotic medications. I believe that if you look at things like MDR and prolonged exposure, I think as long as you can get people into the memory and get anxiety up, so activate the fear network, we generally see it working. I think there's more problems with, but here's my English, benzodiazepines and how do you call these? Help me out, guys. Well, things like
anti-anxiety medications that then inhibit your anxiety response, makes the exposure less effective.
Yeah, and that really doesn't help if you're helping someone to take the step of exposing themselves to situations, etc., and suddenly they're saying, "Oh, I don't feel much because now I have these pills." Then it doesn't work. But generally, there's not that much interference, is my opinion.
Any other thoughts from folks on that, or how to speak to prescribers about this topic, Amy?
I mean, I'd agree with what David said. I guess there can be an issue, though, sometimes with antipsychotics in terms of sedation and that impacting on someone's sort of engagement with therapy. And so certainly, you know, in our work, if that's happening, we would have a discussion with the care team and try and think collaboratively about how we could manage that. And I've certainly had clients who have perhaps, with the agreement of the care team, you know, decided together that maybe we're going to adjust, say, when someone takes their dose for the day, so that they're not kind of coming to session feeling very sedated, possibly even thinking a bit about kind of modifying the dose for a short period.
Wonderful, thank you. So just a couple of seconds for me to say thank you so much to all of our speakers. It's been excellent. I've thoroughly enjoyed it. What a wonderful group. And head on over to room 1 for the closing remarks. Thank you, everyone. Bye.